So, hello and welcome back. This is going to be our first discussion on an approach to rash, and this will be a logical approach to the analysis of skin lesions from the point of view of a doctor in internal medicine. So, we'll first concentrate on developing a mechanistic understanding of how the normal skin functions. So, the deepest layers of the skin primarily are involved in growing upwards. That layer is called the stratum basale, and these cells are alive and are proliferating actively. The normal rate of proliferation is such that a cell that is starts a cell that is formed at the base of the skin reaches the top of the skin or the most superficial layer in about 2 weeks. Along the this process of going from the bottom of the skin or the lowermost deepest layer of the skin to the most superficial layer, there is differentiation. And differentiation in case of a skin cell, that is a keratinocyte, basically means a conversion to a dead plate like cell. Okay. Or what is also called cornification. So as you can see, these cells are going from being almost pillar shaped or cuboidal or columnar to being flattened horizontally and flattened. So after that, what ends up happening is they lose their nuclei. The cytoplasm is replaced by water repelling proteins and lipids, and it eventually dead squams or dead plates are formed. That is what I've represented as blue here. Okay, so this is the normal process of development of within normal skin. Now, what we're going to do is we're going to first learn, as in any other diagnostic framework in internal medicine, we're going to first learn how to localize a skin lesion, because which layer of the skin is involved changes a lot about the likely pathology and the likely etiology of that pathology in the skin. Primarily because the epidermis of the skin, so the skin is made up of the dermis and the epidermis, and the epidermis lies on top of the dermis. The dermis is vascularized, whereas the epidermis receives all of its oxygen and water and all of its nutrients from the dermis. Now, because of that, a blood-borne pathology will affect the dermis, it will not affect the epidermis, whereas the mechanical insults and everything else that the skin is exposed to affect the epidermis primarily. And then the junction between the epidermis and the dermis itself is a area of active immune surveillance and is affected by certain immunologically mediated pathologies, where we get which we are obviously interested in. So I'll be discussing how to localize these lesions into one of these three layers. Okay, and another thing is, although strictly not a skin lesion, lesions below the dermis, that is in the subcutaneous fat, particularly if they're inflammatory, they are termed panniculitis, and they are also something that will be localized. So the first thing that we'll use to localize lesions within the different layers of the skin is actually the borders of the lesions that you see clinically. So here I've drawn three different types of lesions. Okay, one is affecting the dermoepidermal junction or the superficial dermis. One is affecting the deeper parts of the dermis, and one is affecting the subcuticular or the fat planes beneath the skin. Okay, so just for orientation, this is the epidermis. This is the junction or the dermoepidermal junction, and this is the dermis. And although this is not clearly demarcated, everything below this is your subcuticular or subcutaneous fat. Okay, so let's see what happens clinically. So as you can see, it's like see, the more number of, if you have placed bed sheets over a coin, the more number of bed sheets you place over the coin, the less well you can appreciate the borders of the coin. Okay, so that principle applies here. More the layers that are superficial to the lesions, the less is the border of the lesion well defined. The less well defined is the border of the lesion. So let's see how that works out. So in the first case, because it is a very relatively superficial lesion, it's affecting the superficial dermis. It could even be affecting the epidermis or the dermoepidermal junction, but just in this example I've used the superficial dermis. You find that the lesion is very sharply demarcated. So as you can see, this is a lesion that is showing. I can use a pen, okay, and basically sketch out the borders of the lesion completely. Okay, I can sketch out individual lesions here like this. Okay, so these are very sharply demarcated borders, indicating that the lesion is quite superficial, either epidermal or dermoepidermal junction or the superficial dermis. The superficial dermis is also called the papillary dermis because of these papillary projections that form the papillary dermis. Okay, now a deeper lesion that is affecting the deeper parts of the dermis would not be as well demarcated. So as you can see, I can somewhat tell you that okay, this is normal skin, this is abnormal skin, but where the transition from normal skin occurs to abnormal skin is a little vague. In some areas I can sketch it out, okay, but in other areas I am not. See, when I pass or I try to sketch it out, I can't really decide where the line should go. So it is less well demarcated, indicating that this is actually a deep dermal lesion. Okay, and thirdly, this is another lesion, a very similar lesion. So what you find here is that the borders are not at all well demarcated. In some areas maybe you can say they are well demarcated, but in other areas there's this zone of transition that you can see here, okay, going from abnormal skin to normal skin. And in this area the lesion is very poorly demarcated. So so as you can see, the deeper the lesion in the skin, the less well demarcated it is. So a well demarcated lesion would be an epidermal lesion or a dermoepidermal junction lesion, or it would be involving the superficial papillary dermis. A very poorly demarcated lesion would be very deep, so usually involving the subcutaneous fat plates. A lesion that is in between, that is involving the deep dermis, would be somewhere in between in terms of demarcation also. Some areas it will be relatively well demarcated, in other areas it will not. Now there's another thing that brings us to our next point of discussion, that is the level of redness in the lesion. Okay, so you can see that these lesions are definitely very red or pink. Okay, they're very brightly red or pink. These have a slightly violaceous or violet like hue. Okay, and these have even more of a violaceous hue. They're almost purple in color. Okay, so as you can see, the color of the lesion is also changing depending on the depth. So as the lesions are getting more deep, more and more deep within the skin, their color is becoming more and more blue. Now why would that be the case is something that is a very interesting thing. It's because of the phenomenon of Rayleigh scattering. Now see, light is an electromagnetic wave. So because it is an electromagnetic wave, it actually consists of two orthogonally propagating electric and magnetic waves. Okay, so this is the plane and they're perpendicular to each other. Okay, so now light can interact with particles that are either very large in comparison to the wavelength of the light, okay, or it can interact with particles that are somewhere around the size of the wavelength of the light, or it can interact with particles that are much smaller than the wavelength of the light of the wavelength of the light. Okay, so now when these three things happen, we use a parameter which is defined as x is equal to 2 pi times the radius of the particle that is refracting the light, or that is scattering the light, divided by the wavelength of the light. Lambda here represents the wavelength of the light. So as you can see, if x is, the first scenario was when x is much more than 1, that is the particle size that is scattering the light is much larger than your actual light, and that is your routine scattering, the scattering that you see in day-to-day life. When x approximates 1, that is, it is somewhere the particle size is similar to the wavelength of the light. At that point, there are two types of scattering that might happen. Okay, you may get something called Mies scattering, and there is another phenomenon called Raman scattering. And Raman scattering is related to the polarization of the light, so it changes the polarization of the light. We'll get into it later at a later date. What I'm interested in, however, is when x is much smaller than 1. Okay, so at that point we get the phenomenon of Rayleigh scattering. So what ends up happening is your wavelength, this is your wavelength. You got small particles, these may be atoms or molecules, but these are independent particles, okay, that can move independently of each other. The charged particles within the nucleus of that subatomic or the atomic level particle, that undergoes resonance due to the movement caused by this wave. Okay, and with that resonance it starts moving, and when a charged particle moves, it itself produces a magnetic field, and when that happens, it radiates energy. Okay, so when it radiates energy, that is what we call Rayleigh scattering. Okay, because it radiates, radiation will be in all directions, it will not be in the direction of the light, incident light. So it will go in all directions like this. Okay, so that is the phenomenon of Rayleigh scattering. Rayleigh scattering is given by a rather interesting, elegant formula. So Rayleigh scattering, the intensity of scattered light is directly proportional to the fourth or the sixth power of the radius of the scattering particle, and inversely proportional to the fourth power of the wavelength of the light that is causing the scatter, or that is rather getting scattered per se. Okay, so what does that means? The more, that means as the wavelength of the light increases, more scattering occurs. Okay, and when scattering occurs, that light will move randomly in various directions, and therefore your eyes and your brain don't perceive it as coming from that particular object. Okay, so you are able to tell the color of an object when light of a certain wavelength from that object directly comes into your eye. So if that light is getting scattered, it will not reach your eye, and therefore that part of the color spectrum of that object will be lost. Okay, so now what happens with erythematous lesions is, say you have, like in our previous scenario, a lesion that is rather deep in the dermis. Okay, it's somewhere here in the dermis. Now even though the lesion is red in color, okay, it will have red wavelengths coming out. Okay, so light will be incident on it, and then will get reflected from the lesion, and there will be some blue wavelengths coming out. Now blue wavelengths have much shorter wavelength than the red wavelength light. Okay, so because there is a lot of tissue in between the surface of the skin and the lesion itself, okay, a lot of this red light will actually get scattered. It will go in various directions. Okay, whereas the blue light, because its wavelength is much shorter, is not actually getting scattered much. So when the light, the compound waveform of the light comes to your eyes, you actually appreciate much more of the blue component of the light, and as a result the lesion starts looking more and more, the lesion, even though it is actually red, it starts looking more and more bluish. There's a bluish tinge to the lesion, and that is why in the previous example, as the lesions were getting deeper and deeper, there was a bluish tinge. Okay, so this is the basic concept behind this, using the color of the lesion to localize the level of the lesion within the skin. Now how is this diagnostically relevant? So diagnostically speaking, in any raised skin lesion, okay, now this is important, I'll discuss why it is important that it is a raised skin lesion, okay, at a later time. But most inflammatory pathologies will either cause an epidermal reaction, in which case the epidermis will become thickened so that the lesion will get raised, or there will be some kind of dermal or subcuticular infiltration. So in that situation the lesion gets raised. Okay, if it's not raised, there are some other considerations, and the lesion is less likely to be red in color, or have an inflammatory component causing vasodilatation, giving it a red color. Okay, so anyway, in any raised lesion, we look at two parameters. We look at whether the lesion is well demarcated, so that could be yes or it could be no, and we look at whether the lesion is red in color. Okay, it could be yes and it could be no. So obviously in this category, where it is a red lesion and it is well demarcated, we know that it is very superficial. So if it is very superficial, these are the three possibilities as I've just alluded to. That is, it could be an epidermal lesion, it could be a dermoepidermal junction lesion, it could be a superficial dermal lesion. Okay. Now, on the other hand, if a lesion is neither reddish in color, that means it's violaceous, as the color of the no here, and it's not well demarcated. Okay, it's likely either deep dermal lesion, okay, or it is a panniculitis. Okay, that means an inflammation of the subcutaneous fat plates. On the other hand, what you may have is a lesion that is reddish in color but is not well demarcated. Okay, so such lesions usually are, it is red in color, so it has to be superficial. Okay, but there are parts of the lesion that are extending deeper into deeper tissue, and the light that is incident on that area of the lesion, as it is coming out, the red components are getting filtered out. Okay. On the other hand, you may have a lesion that is violaceous in color, that is not red in color, okay, but has well demarcated borders. So it may not be violaceous, any other color other than red. So if this can happen in two situations. One is when you have a person whose skin is otherwise having a lot of pigmentation, the person is darker in general. So in that situation, the differential diagnosis is the same as this, because we know that the lesion is well demarcated. So since it is well demarcated, it should be superficial. Okay. Now, therefore, the lesion must be either epidermal, dermoepidermal junction, or superficial dermal in origin. Okay. Whereas if the person is not generally having a darker skin tone, the other possibility is that the lesion is itself not red in color. Okay, so the lesion may not be inflammatory, and therefore it may not have a reddish color at all. So this is the first step of deciding what kind of a pathology we have. Now, coming to the next point. So in this discussion, we'll be going into the details of how to differentiate these different types of sharply demarcated and erythematous lesions, because these are all either epidermal, dermoepidermal junction, or superficial dermal, and they often cause visible changes in the appearance of the epidermis. And the thing is that these epidermal reaction patterns can be deduced even with a gross examination of the skin. So even on gross examinations, if you apply logic and reasoning appropriately, with deduction you can actually infer what is the likely microscopic change or reaction pattern that is active in a particular lesion. So we'll start with the first reaction pattern, that is psoriasis. Now please notice I have used the term psoriasis, and psoriasis also refers to a specific disease. Okay, so this was the normal pattern of differentiation that we had. There was some growth, then the cells were undergoing differentiation, and then finally they were dying, and then they were getting desquamated. Now in psoriasis, on the other hand, what we get a lot of growth. Okay, the stratum basal, or the basal epidermal layer, grows there is florid growth. Okay, and so as you can see with the multiple layers of cells that I've drawn. Now, because they're growing so fast, they don't really have time, or they're not able to mature adequately. Okay, so differentiation is occurring relatively normally, but there's just not enough time for the cells to undergo differentiation. Okay, and because of that, the desquamation occurs not in fully cornified cells. So grossly, when you look at this, they're not as loose as the fully cornified cells that you see in normal skin that get desquamated. So that looks like dust, and it's actually not visible. Okay, whereas these cells are still sort of sticking to each other. Because they're sticking to each other, they come off as grossly visible flakes. Okay, so because of this, one is that the lesion thickness is increased, as you can see in this, as with the diagram. Second thing is that the lesion obviously will be sharply demarcated, and third would be that there is a superficial scaling or desquamation that is visible even grossly on gross examination of the lesion. The second reaction pattern is what is called lichenification. So epidermal reaction pattern is lichenification. So in lichenification, the growth is actually not happening as fast as it normally does, or maybe is normal but it's not increased. Okay, but what is happening is that there is excessive and premature differentiation of the epidermal cell layers. So as you can see, even the stratum basal in this example that I've drawn here, the cells are actually not columnar, they are flattened. Okay. Now, because of that, what ends up happening is the differentiation occurs very early in the or the at the basal layers of the epidermis. Okay, and that produces a skin that is it's thickened and it's coarse. It's actually a normal skin response to a recurrent mechanical trauma, and we'll get to in a subsequent discussion. We'll get to what are the molecular mechanisms behind that. Okay. Now there is a reaction pattern called psoriasiform. Okay, there's a difference between psoriasiform and psoriasis. So what is the difference? So on the left side, I've shown you again the diagram of psoriasis, a psoriasis lesion. So there's a lot of growth happening. Okay, and differentiation is essentially normal. Now in psoriasiform lesions, you don't have excessive growth. You have normal or decreased cellular growth in the stratum basal. What you do have is actually an impairment of differentiation. Okay, so the differentiation of the cells as they go from the base to the superficial most layers of the skin is actually decreased. So because of that, very similar to a psoriasis lesion, we have the superficial most layers of the skin not being fully cornified. So they flake. Okay, but the lesion is not as thick. Okay, the thickness of the lesion is not as much as you would expect in a lesion that is true psoriasis. And the other thing is that actually the growth rates of the cells are not really increased. Okay, so clinically this translates into the uric acid levels say not being elevated, because that reflects increased nucleotide metabolism because cells are actively dividing, which is a characteristic feature in psoriasis. So they are similar, but psoriasis has increased cell growth, okay, which is resulting in the normal differentiation not occurring because there's just not enough time. Whereas in psoriasiform lesion, there is something that is actually actively impairing the differentiation, although the growth rates of cells within that lesion are not actually increased. Okay, it's a subtle difference, but it's important. Now, okay, so now let's use this understanding to build quote unquote the gross morphology of these lesions from ground up. Okay, now for psoriasis, what do we find? Now this is our psoriasis lesion. What you can see is that the skin is actually a little thickened. The epidermis is thickened. Okay, and not only is it thickened, there is a epidermal hyperplasia. Hyperplasia obviously refers to an increase in the number of cells. The thickening is very regular. If I draw a line joining all of these tips of these papillae, what you find is that the line is relatively smooth. Okay, a normal line would go something like this. So that is a little odd. The second thing that we get is that there is a fusion of the different what are called the rete ridges. Okay, or here also you can see there is fusion of these rete ridges. Okay, and all of this indicates that there is increased growth, okay, of cells in this layer, in the epidermis. Finally, what you find is, and this is a little subtle, but you see these white spaces in these right next to the epidermis, and within those white spaces are small red dots. Those are actually RBCs. Okay, and those dilated spaces are actually dilated superficial dermal capillaries. You don't really find such large capillaries so close to the epidermis in normal skin. Okay, you expect capillaries to be visible here. You don't expect them to be visible here. Okay, so that's a little odd. So all of that indicates that the epidermis is growing. The cells are growing very rapidly, and they're using up, they require vasculature to supply them with the nutrients and oxygen required for that growth, and that is why you have these findings. Okay, now when we do high power, and see, when I talk about high power, I mean low power means a 40 times magnification, and high power means usually a 200 times magnification. Okay, fine. Now there are three features on the high power microscopy that are quite obvious. One is that there is a thinning of the epidermis on the just above the papilla, so the suprapapillary epidermis. Okay, now why is this happening? Because there's impaired differentiation. Okay, the second thing is, although I did not talk about this much earlier, usually just before the cells die and get fully cornified, right, there is a cell layer called the granular cell layer. Okay, and that is a basophilic, it contains cells that have basophilic granules, so it appears like a layer of bluish layer just before the cornified layer. Okay, and that layer in this case, as you can see, is not visible. So why is that not visible? Because again, there is no time for the differentiation to have occurred. Okay, so again indicating that impairs impaired differentiation. The third thing is that there is something called confluent parakeratosis. Now, what does this parakeratosis mean? So, para ortho would mean in the right direction, and para would mean strictly speaking adjacent to the right direction, but not in the right path. Okay, so see, what you expect with the cornified layers of the epithelium, that is this layer, is that there would be no nuclei within the layers. Okay, but you can see there is a lot of bluish dots here, and those are obviously nuclei. So that kind of abnormal epithelium in the cornified layer, or what would be the superficial Morse layer, in this case it's not fully cornified, is very odd. Okay, so that is because the cells have not had time to fully differentiate and lose their nuclei. So they have retained their nuclei and have not had the time to lose their nuclei. So that also indicates that there is impaired cellular differentiation. Now finally, there is another important finding here, that if you can see, okay, so I'll just show it to you in this diagram. You can see that there's a little bit of a edematous interstitium in the, or it's most obvious here. Okay, so here you can actually see that there is a little bit of edema, or there's a little bit of a for want of a better word, softness to the image there. Okay, that is because there is a leakage from those newly formed capillaries, and that causes superficial dermal edema. Okay, so now there's a characteristic neutrophilic infiltrate in psoriasis lesions, and this is because the lesion is caused by TH17 polarization, and we'll discuss this in detail in the next video, but let's for now put a pin in it. And what we find subcorneal lesions, or just below the corneal, the stratum corneum. We find basically what is a pustule. So this is a collection of necrotic neutrophils. Okay, and if you look carefully, those are actually neutrophil nuclei. They are multi-lobed nuclei like this. Okay, okay, and we also find, and so this has been given a moniker that is called the spongiform pustule of Kogoi. Okay, and then we also find neutrophils, because the cells are proliferating so fast that the cells that are dividing at the base of the epidermis reach the superficial most layers of the epidermis within a day or two. So that pustule then gets pushed up and sandwiched between layers of the epidermis. Okay, and this kind of a accumulation of neutrophils within the two layers of the epidermis is technically not possible in normal skin. Why? Because the normal epidermis has no blood vessels, and so neutrophils cannot enter into the normal epidermis, because they enter any tissue via the blood vessels. Okay, so that is naturally not to be expected. So what has actually happened is that neutrophils entered here at the basal layer, and then the basal layer was proliferating so fast that the neutrophils actually got trapped in between. Okay, and then now they've been pushed up. So this is what we call a Monro microabscess, and actually this flattened, sandwiched neutrophilic debris between layers of cornified epithelium has been called the sandwich sign on histopath. Okay, so I hope that much is clear. So now grossly we find this is the imaging or the clinical appearance of the lesions. What do we find? We find something very interesting. Okay, so one is that there are some yellowish small dots, if you would notice, in different parts of the lesion. So this, and a little bit over here. Okay, so there are some subepithelial, almost yellowish necrotic debris there. Okay, that is a result of that neutrophilic infiltration. You may not always get there. Okay, but what you do always get is, one is the lesions will be well demarcated. Okay, and that is but obvious because as they are epidermal lesions. Okay, second is the lesions are quite red in color, and again this is because these lesions are actually quite superficial, and light reflected from these superficial lesions does not undergo significant Rayleigh scattering, so the red components are not filtered out. Also note, the granular cell layer is also gone, so it's actually the granules within the granular cell layer that cause most of the scattering. So that is naturally there's going to be less scattering. Okay. The last thing is the lesions are very superficial, so you actually get this kind of desquamation. Flakes of skin are actually coming off, and we've just discussed that is because they are not been terminally cornified, so the cells have not separated from one another as happens in normal skin. Whereas in lichen planus, what do you see? Okay, so this is a low power view in lichen planus. What we find is that the skin thickness is not significantly increased. It is okay, not thin for normal as compared to normal skin, but not significantly increased. Okay, what we find is that there is a anti-stratum basal adaptive immune response. Okay, so those lymphocytes that are targeting the stratum basal have infiltrated the superficial dermis in many, in droves, in large numbers, and those are visible like a band or a band like infiltrate in the superficial dermis. Okay, now the granular cell layer is actually thickened, and this is more prominent than you would find in normal skin. Okay, so it's very prominent. It's so prominent that I can actually, even in the low power, look at it and tell you that that is the granular cell layer. Okay, and then we have this band-like infiltrate of lesions that are in some parts obscuring the dermoepidermal junction. So in this lesion here, the band of lymphocytes is actually obscuring the dermoepidermal junction. Okay, then we also have some degree of superficial papillary dermal fibrosis. So here you see there is almost a pinkish hue to the superficial papillary dermis. Okay, now in high power, so in high power, what we find is there are because of increased premature differentiation of the cells, we find some very interesting things. One is that there is a wedge-shaped hypergranulosis, or the granule cell layer is thickened and is wedge-shaped. The second thing is that there are certain necrotic, very red bodies. Okay, these are actually necrotic keratinocytes, which are called Civat bodies. There's a specific anti-basal cell layer immune response, adaptive immune system or spell response, predominantly done by CD8 plus T cells. Okay, CD8 plus T cells, that is killing off these cells essentially. Okay, and those necrotic cells are then forming this kind of these bodies, what are called Civat bodies, and these are colloquially, at least in generally in dermoepidermal junction lesions, are considered are called dead rats. Okay, now look at the lesion. Grossly, what does it look like? Okay, the lesions therefore are, one, sharply demarcated, again because they are very superficial, but do notice they're not as well demarcated as you would have expected with or as what we saw with psoriatic lesions. Okay, and this is because there is a component of the lesion that is actually deeper, that is that band like superficial dermal infiltrate, and similarly because of the same reason, lesions are not as red either. Okay, they are little violaceous. Okay, now the next is the lesions are purple in color. So the reason for this is the part of the lesion is deep. Okay, the second is that the granule cell layer is also thickened. So since the granule cell layer is thickened, that is able to scatter more of the red components of the light through Rayleigh scatter. Now there's another interesting thing that is there. You see a whitish, almost retiform layer on top of the lesion. This kind of whitish retiform lace like lesion on top of the lesion, that's actually the granule cell layer itself. Okay, which is actually, the granules are so large they're actually causing full-fledged scattering, so that's producing a whitish color. Okay, and not just relay scattering. So this is actually highly characteristic of lichen planus. It's not specific for lichenification. It's specific for the specific disease that is lichen planus. Okay, so now there's a mnemonic that is used classically in dermatological literature, and that is commonly taught in medical school. That is the 6 P's. That would be so there's a mnemonic that is used that has classically been taught in medical college. That is that the 6 P's that are there, that are characteristic of lesions of lichen planus. That is a polygonal P. 1 P stands for polygonal. That refers to the shape of the lesions. Okay, it's actually the highly sharply demarcated nature of the lesion that is being referred to. Planar or flat. Okay, because these are obviously flat topped, like all epidermal lesions. These are flat topped. Papules or plaques, again, because they are either, if they're very small, the flatness may not be apparent, or plaques refers to a lesion that is slightly large in size and is flat topped. Okay, I'm not going into the definitions of it because actually that doesn't really help you in differentiating lesions, so I don't really want to waste your time on nomenclature. And planar and and purple for, because there's more relay stratum than expected happening, and pruritic lesions. So now we have psoriasiform lesions. So what do you find here? You find that the thickness of the lesion is actually not increased. Okay, the epidermis is actually thinner than expected. That is a very characteristic telling thing. Okay, there's just essentially impaired differentiation of the epidermis that's happening here. It's not impaired differentiation is not being able to keep up with the growth rates of the epidermal cells. It's just that it's just not happening. Okay, and epidermal thinning is in this case also associated with parakeratosis. Now this is parakeratosis because, so you can see that the cornified layer here also has nuclei in it, but that is, and there is an absence of a granule cell layer, but this is because of impaired differentiation. The cells are just not differentiating into the granular cell layer or the the cornified layer. And finally, what we have is, we have a band-like infiltrate of lymphocytes. You can see it in this diagram as well. Okay, so that actually depends on what lesion is causing the psoriasiform nature of the lesion, and it can vary even within the same type of lesion. Okay, but for now we'll not go into that. So this is a characteristic feature that is due to the effects of production of type 1 interferon. Type 1 interferons are a type of cytokine that are produced by the immune system in response to viral infection, and they tell surrounding cells that a virus has infected one of the cells. And with that information, what the cells do is, a virus is a obligate host. Okay, it requires its host cell to survive and replicate. So if the host cell itself shuts down its protein synthesis, the virus cannot use that protein synthesis machinery to replicate itself. So the main defense of any mammalian cell to viral infection is actually to shut down its protein synthesis, and that actually is the reason why there is that epidermal thinning, because obviously protein synthesis is required for cell growth and differentiation. So that is why differentiation is not happening and there is epidermal thinning. Okay, now what you also find is the cells very similar to those Xivart bodies, that is highly eosinophilic cells present within the epidermis. These are also called dendrites. These are also necrotic keratinocytes, but they are not called Xivart bodies because Xivart bodies are specifically were described in lichen planus. Now you find vacuoles at the dermoepidermal junction. Okay, so this is actually a characteristic feature of a type of interface dermatitis, histopathological type of interface dermatitis called vacuolar interface dermatitis, and it essentially indicates, describes those parts of the dermoepidermal junction where a necrotic epidermal cell has undergone necrosis and is no longer present. Okay, so the normal integrity of the dermoepidermal junction there is lost, and fluid has then accumulated in that area. Okay, so when you prepare the section for histopath, at that point that particular area becomes whitish in color. Okay, now grossly, see, this is something very interesting. So what you find is that the lesion is slightly violaceous. Now it is violaceous because there's a deep dermal lymphocytic infiltrate, but it need not be. It might as well have also been erythematous. It depends on how much the superficial dermal infiltration was there. So that is something that is a histopathological finding, but that you can surmise even or deduce even from gross imaging. Okay, that is the aim of my discussion today. The lesions are very well demarcated, again because they are very superficial. Okay, and they involve the epidermis and dermoepidermal junction as well as the superficial dermis. Now those areas where they are involving the superficial epidermis, they are not as well demarcated. So if you can see here, this line is actually not that sharply demarcated, whereas on this side the lesions are highly sharply demarcated. Okay, so probably in this area there is involvement of the superficial dermis, on the other areas there is not significant involvement of the superficial dermis. Lesions are violations in color, again because some parts of the lesions are deeper. Okay, they are within the superficial dermis, and therefore the light reflected from those deeper parts of the lesion are undergoing Rayleigh scattering. As a result, a lot of the red components of the light is actually getting scattered out. Okay, and lastly the lesion show desquamation. Okay, again very similar to that. To psoriatic lesions, so because the layers are not adequately quantified. Okay, so in summary, psoriasis lesions develop as a result of epidermal hyperplasia or cellular division, okay, resulting in impaired normal epidermal cell differentiation because there is just not enough time. Okay, lichenified lesions develop as a result of excessive and premature epidermal cell differentiation. Okay, so there is increased differentiation. This is an exact opposite of actually a psoriasiform lesion, where the rate of cell division is normal but differentiation is not occurring normally, and that is the result of local production of type 1 interferon. Okay, so not only can I deduce the histopathology of a lesion by looking at it, I can even deduce the molecular basis of how the lesion is formed. So you can see just an understanding of the basic constraints of your system can give you a lot of detailed understanding of what may be happening. Okay, now some things are lost in semantics because again this is a dermatology topic, and I am an internal medicine doctor, so there are some things, say, I wouldn't have named them this way, but this is how it is been named in dermatological literature. So these terms psoriasiform and lichenoid are therefore inherently confusing. Okay, so psoriasiform actually refers to the gross morphological appearance overlap of psoriasiform lesions with those lesions that represent true psoriasis. Okay, so both lesions have a epidermal cell layer that is not being able to undergo differentiation, but in case of psoriasiform lesions, it's because the type 1 interferon is not allowing normal cell differentiation to occur. The exact molecular mechanisms for that we'll come to in detail when we discuss interface dermatitis, but again in psoriasis there is actually cellular hyperplasia, and that is preventing adequate differentiation from occurring. Okay, so mechanistically the two lesions are different, so I wouldn't have called these lesions psoriasiform. Okay, it results in confusion. The second thing is lichenoid. So lichenoid actually refers to the histological appearance of that band-like superficial dermal lymphocytic infiltrate, and therefore has essentially nothing to do with lichen planus. Okay, other than that, on histology it resembles lichen planus. Okay, so it neither represents the gross morphology overlap, or nor does it represent a mechanistic continuum. Okay, so like I said, psoriasiform just implies that the lesion is there is local production of type 1 interferon. Okay, and lichenoid just refers to the biopsy finding. Now so as doctors of internal medicine or internists, it's better we think mechanistically because that is what we're better at. Okay, so I use these skin lesions to actually infer the likely underlying immunological mechanism. Okay, so how does one do that? So what one does is one takes the three mechanisms that I discussed on my discussion on the patterns of, or logical approach to the patterns of inflammatory arthritis, and tries to apply it to this situation. So the three patterns, just to reiterate, the three mechanisms I just to reiterate were, one was increased innate immune activation, which was either intrinsically an issue with the innate immune system, or it was due to in impaired Th17 to Th1 polarization, because Th17 enhances innate immune activation and Th1 inhibits it. So if there is an impairment in that transition, there would be prolonged innate immune activation. Okay. The second situation is when you have an increased adaptive immune activation due to a specific immune response against a specific antigen, and this specificity obviously can only be provided by an adaptive immune response. So that happens when you have an specific adaptive immune response. Okay, an example I used was rheumatoid arthritis and psoriatic arthritis, but polyarticular psoriatic arthritis. Now the third example was when the innate immune system actually is being activated excessively by the adaptive immune response, because the adaptive immune response happens to produce antibodies that bind to proteins that in turn bind to nucleic acid, and the removal of these antibody antigen nucleic acid complexes by your dendritic cells, specifically the plasmacytoid dendritic cells, results in the accumulation of these nucleic acids within the endocytic vesicles of said plasmacytoid dendritic cells, and therefore increased type 1 interferon production. Okay, so these were the three mechanisms that we've discussed, and they also they also map quite well onto the spectrum of cutaneous changes that we might find in this disease. Okay, so in psoriasis, in neutrophilic dermatosis, in pseudofolliculitis, or in any other neutrophil mediated disorder, or in aphthous ulcers and neutrophilic dermatosis in general that are ulcerative, the first mechanism is at play. Okay, so actually if you recall, diseases such as Behçet's disease, okay, and the spondyloarthritis spectrum disorders have these kinds of skin lesions. Okay, and clinically we go in the reverse order, so we see these lesions and we infer that the underlying pathophysiology is likely this. Okay, second is your lichen planus, because like I've just discussed, lichen planus, there is a specific anti-stratum basal adaptive immune response. It could also be granulomatous dermatitis, but usually there is no idiopathic granulomatous dermatitis per se. Okay, the third is your psoriasiform lesions, because they are resulting from type 1 interferon production. They would obviously be in the third category. Okay, so lesions in SLE, dermatomyositis, and Sjogren's syndrome often have significant physiological or clinical morphological overlap, and even histopathological overlap. And in fact, per se, there is no sharp boundary that differentiates the erythematous lesions within dermatomyositis and SLE. Okay, they are essentially the same, although generally it is said that SLE lesions have more of a superficial dermal infiltrate, whereas your dermatomyositis lesions don't. But that is not strictly the case, and we'll get into that when we talk about interface dermatitis. Okay, now there is another interesting entity, that is when you have superficial vessel vasculitis or small vessel vasculitis secondary to antigen antibody complex deposition, or excessive type 1 interferon production resulting in endothelial dysfunction which causes secondary vasculitis, or ANCA resulting in neutrophil activation which causes vasculitis. So vasculitis technically can occur in either the second category or the third category of disorders. That is, it can occur when there is a specific adaptive immune response, and it can occur when the adaptive immune response is enhancing the innate immune production of type 1 interferon, and this will require a little bit of fleshing out at a later date. So we'll be discussing the cutaneous manifestations of monogenic autoinflammatory disorders. At that point it will become quite clear. Okay, so that brings us to the end of this discussion. It's not something that most internal medicine doctors are comfortable with, but I hope I have been able to give you a good mechanistic understanding of what it is and how to localize the lesion, and then how to infer the underlying mechanisms based on the lesion morphology, and what the basic physical principle behind that is. So I'll see you in the next video in this series, and that will be an a discussion on the um, basically the interface dermatitis, and then we'll go into, I will move deeper in lesions, we move to lesions that are deeper in the skin layers of the skin. So thank you, and I'll see you next time.